Hello, my name is George Kovalevsky, and I'm one of the reproductive endocrinology and infertility specialists at the Delaware Institute for Reproductive Medicine in Delaware. Um, this is a week that focuses on infertility awareness, and we are doing this webinar today to try to bring more attention to infertility and try to help answer any questions that are out there at this time. So to begin with, I'll just talk a little bit about infertility in general and women's age, and then we'll get to questions that you'll be sending in. Infertility affects about 15% of couples in the United States. This is a rough estimate because we don't have any great data and no great ways of obtaining this data overall. There is increasing infertility largely because of delay of childbearing. Women are in general waiting longer in this country before attempting pregnancy. And that translates into higher incidence of having difficulty becoming pregnant and having children. There are a number of possible explanations for why that is, but the single biggest reason is that age is directly proportional to ovarian reserve. So we know in general, as women get older, they have fewer eggs left, and the percentage of eggs that are chromosomally abnormal continues to increase. So an average female fetus starts out with something like 6 million eggs in storage, and then by the time the female baby is born, down to just about 1 million, and maybe at time of puberty down to 500,000. And from there, the egg supply continues to diminish until the eggs are all gone, and that's menopause. So my simple-minded way of thinking about this is that every woman is born with a basket of eggs. And as you go through your life, you use up those eggs. In the teenage years, the 20s, we're starting with the best eggs at the top of the basket, and the chances of pregnancy are high, risk of miscarriage is low. By the time an average woman gets to the mid-30s, then she's entering about the middle of the basket, where half the eggs are chromosomally normal and half are now chromosomally abnormal. Because of that, the chance of pregnancy is going down, and the risk of chromosomal problems like Down syndrome is going up. By the time an average woman gets to her 40s, she's getting towards the bottom of the basket, where most of the eggs are chromosomally abnormal. And that's why low pregnancy rates, high miscarriage rates, high risk of Down syndrome, and those types of chromosomal abnormalities. Nothing we can do to reverse that. We can't put new eggs back into the basket, can't flip a switch and make new eggs. What we have is what we have. That's what we have to work with. There are tests that allow us to estimate the ovarian reserve, and certainly those are tests that we use routinely in the office. And so age, number one, and ovarian reserve, number two, are markers for how someone will respond to fertility treatment and what their chance of success will be overall. So the best advice we can always have for anybody is to not delay childbearing whenever possible, and to have children and complete childbearing earlier in life whenever possible. There are also techniques for fertility preservation, because we can freeze eggs or embryos for the future. These are not means of guaranteeing that there will be a successful pregnancy in the future, but they're ways that we can increase the odds of success if an individual has difficulty achieving pregnancy with her own eggs later on in life. So with that introduction, we can turn to some of the questions. The first question asks, how would you know if you're ovulating? There are a number of ways that this can be determined. So certainly the first and the easiest is simply seeing if somebody has a regular menstrual cycle. So if you are having a period regularly every 28 or 30 days, or a consistent number of days every month, that is strong evidence that ovulation is taking place. It's not 100%, but it's close. It's a very good marker. If we want to do testing, there are a number of things that can be done. Without seeing a doctor at home, there are ovulation prediction kits that are available. They check the LH surge in the urine. They are pretty good for women who are ovulating regularly. They're pretty good at determining when ovulation is going to be taking place. A woman can also do other things, such as look at the cervical mucus and see if it goes through the characteristic changes at that point in the month. Temperature charting, where the temperature should go up about 0.5 degree, but after ovulation takes place. In the office, we mainly rely on a simple blood test. After ovulation occurs, the progesterone levels will rise. And so measuring progesterone in the blood will tell us if someone has ovulated that month or not. There are other tests available as well, and so we can keep going with those, but they become less practical. For example, doing an endometrial biopsy and looking at that tissue from the uterine lining under the microscope, that tissue goes through characteristic changes under the influence of progesterone, so it will also be diagnostic for ovulation. We can do monitoring in the office with ultrasound, so we can see if there's a follicle that develops on the ovary, and then after ovulation, we see that that follicle disappears and maybe a corpus luteum forms, which is the structure that produces progesterone after the egg has been released. So a number of different ways, some ways that individuals can do at home on their own, and some ways that we can do in the office. The most common, most reliable way for us usually is to simply check the blood for the progesterone level. Can you share about the impacts of vitamin D deficiency in male and female fertility? So overall, this is not as clearly delineated. We know that vitamin D levels impact many areas of health, including fertility. We don't know for sure the mechanisms by which fertility is affected. A number have been proposed. Egg quality is suspected to be impacted. And so in general, we always attempt to have normal vitamin D levels, both for health and for reproduction at the time of fertility treatment. So we aim to have the vitamin D level above 30 as a good place, less than 100, because there are risks of going too high. Reading the next question, which is a little bit lengthier. The individual is 42 years old and has had failed fertility treatment cycles. The embryos were described as of good quality, but just simply did not implant. So, unfortunately, age is the biggest predictor of success. And so when we do IVF in women who are older, we are faced with a number of obstacles. The first, and one that's difficult to overcome, is that ovaries may not respond to stimulation. So regardless of the protocols that we use, the doses, we have a number of tricks that we try to utilize. If a 42-year-old woman has low ovarian reserve, as she often does, then the ovaries may not respond to stimulation very well, and so very few eggs will be obtained. Having few eggs, knowing that statistics at 42, most of the eggs are abnormal genetically, chromosomally, it's unlikely that we will achieve a healthy blastocyst. So playing the odds is the problem, is that there's very little that we can do to overcome that. In this particular question, you're reporting that you did have good embryos that were achieved, but they did not implant. So there are a number of possibilities why embryos do not implant. The first is that they may not have been normal embryos. So embryos are often achieved, but at 42, we know that the majority of embryos that are created are chromosomally abnormal. And that is why we often discuss whether we should utilize a technique called pre-implantation genetic testing, PGTA, which allows us to check if the embryos are chromosomally normal or not. And then if the embryo is abnormal, it's not likely to implant. If it does implant, usually it will be a miscarriage. And then with some of the abnormalities, a child may be born with chromosomal problems like Down syndrome. Right? But the majority of chromosomally abnormal embryos will not implant at all. If the embryos have been tested and are still not implanting, we always want to make sure that the uterine environment is appropriate. Is the uterine lining developing the way it should? Is there anything wrong inside the uterus? Scarring, polyps, fibroids, infection. So there are a number of other things that we always try to make sure of in those types of situations to give the embryo the best possibility of attaching. But the number one most common reason that we talk about is that chromosomal abnormality of the embryos, and PGTA is very useful in those who do have adequate response and make several embryos so that we can identify the good embryo that has the best chance of success and not spend a lot of time doing transfers of abnormal embryos. In terms of miscarriage for older patients, same thing. So we always make sure that the uterine cavity, for example, is normal and nothing that's going to impact good implantation and increased risk of miscarriage. In individuals who have recurrent pregnancy loss, who've had multiple miscarriages before, there's testing for other more rare conditions that we want to rule out, problems like antiphospholipid antibody syndrome, and some other things that we can test for. And the ultimate most important reason usually is the chromosomal testing again of the embryos if we've ruled out all the other issues. Next question. Why would you want to know if someone was a few days late for their period in the past? What does that indicate? Chemical pregnancy, potentially. Yeah, so there's always going to be some natural variation in a normal menstrual cycle. So most women do not have periods exactly every 28 days. There's some cycles that are a day late, 2 late, 3 days late, some that are a couple of days early. So there's always going to be some variation, and that's normal biological variation. So usually we don't make too much of it if someone is a couple of days late with their period. Having said that, we do know that chemical pregnancies or biochemical pregnancies are very common, and maybe another reason why sometimes a period comes not just a couple days late, but maybe 5 days late or a week late. Or maybe the ovulation was late for other reasons. Maybe there's an ovulatory dysfunction. So just quickly to explain, biochemical pregnancies are pregnancies that we know are established on embryo implants somewhere, usually in the uterus, but not necessarily. So an embryo does implant, there is a pregnancy, but that pregnancy fails very early on, so that it's a very, 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 very early miscarriage. And so most individuals who are not keeping track of their cycles or not doing testing regularly would not even be aware that an implantation occurred and simply would think this was maybe a slightly late cycle. It doesn't usually really change anything that we do. So in practice, it does not usually alter the management very much. If we do document multiple biochemical pregnancies, it would suggest more that there's increased risk of chromosomal abnormalities perhaps in this individual, but that's not well established. How much does inflammation affect getting quality embryos? What are suggestions to reduce inflammation? Great question, and one that we don't completely have answers to. So we know that inflammation in general, as in our bodies, is something that impacts many areas of health. We know that inflammation impacts our cardiac health and our joints and many other aspects of our functioning. How it affects fertility is much more difficult, and we don't have answers for that. The most likely effect is on the egg quality. And so the biggest aspect of egg quality, when we talk about quality, is chromosomes. Are the chromosomes normal or not? But there are other aspects as well, and these we may have some control over. So the lifestyle that we live, the diet that we eat, the stress that we go through, potentially impact egg quality to some degree as well. So when someone is trying to conceive and is planning to do fertility treatment in particular, we always discuss that healthy living is something that can make a difference and is strongly encouraged. So healthy living includes avoiding the bad things, drugs, smoking, alcohol, and doing the good things. So eating fresh foods, mostly a high protein diet, a low carb diet, less processed food, trying to minimize stress and manage stress, exercise in moderation. So healthy living and inflammation may be a part of that healthy living concept. It's very hard to delineate it any further than that. And so certainly there are no treatments for inflammation that are recommended to improve fertility outcomes at this point. Can you be on depression medications like Zoloft while doing IVF, or will they interact poorly? Yes, you can be on medications, this class of medications known as SSRI, selective serotonin receptor. And so the SSRIs as a class are used very often to treat depression, and it is very common that we have patients that are using these medications that are undergoing fertility treatment, and there's no reason that they have to stop the treatment, the medication during the fertility treatment. For age 38 with low anti-Mullerian hormone AMH and recurrent pregnancy loss, would you recommend day 3 or 5 for a fresh transfer? So when to transfer the embryo is the question in this particular case, and in general. So when an IVF cycle is done, the eggs are retrieved and combined with the sperm, and then the embryos are created. We count the days from there, and so sometimes transfer is done 3 days after retrieval. The vast majority of transfers that are done in the United States and in our practice is on day 5. The main reason for waiting to day 5 is because the embryos start to reach the blastocyst stage at that point. And we know that the embryos that make it to the blastocyst stage have a higher chance of being normal, chromosomal and in other ways. So it's kind of a survival of the fittest concept, that the stronger, healthier embryos are the ones that make it to the blastocyst stage, and therefore have a higher chance of success. Embryos that do not make it to blastocyst are likely abnormal and would not have succeeded had they been transferred on day 3. So there is some thinking that what if the embryo is on the weaker side, and maybe could it have survived in the uterus, because the uterus maybe is a warmer, friendlier place for the embryo, while it doesn't survive in the laboratory to day 5. In general, I do not subscribe to that thinking, because we have largely worked out the best environment for embryos to grow in the laboratory. Over the years that IVF has been done, we have figured out what the embryo needs to thrive. So in our laboratory, in the incubators, everything is controlled rigorously. That includes the temperature, the acidity, the oxygen concentration. So it's the perfect environment. The air is cleansed. There's the best HEPA filters to clean the air, to reduce any kind of harmful chemicals. So really, the environment is as optimal as possible for that embryo to grow and thrive. And I would guess that it could be better than in the uterus on many levels. So I do not believe that if the embryo did not survive in our laboratory to blastocyst stage, that it had any chance of surviving better in the laboratory if we had transferred it on day 3. So it is very rare that I would ever transfer embryos on day 3, only in very rare circumstances, but rather always wait to day 5. If the embryo does not make it to day 5 and there's nothing to transfer, then we know it would have been a wasted effort anyways. And it would not have been of benefit to anyone to go through the transfer, and then the time period waiting to do a pregnancy test with medications, etc. So In this case, no different. I would recommend waiting to day 5 for a fresh transfer if a fresh transfer is done, and the low AMH does not impact that. If you have recurrent pregnancy loss, and the most likely, the single biggest reason for miscarriages is chromosomal abnormalities overall, I would strongly consider doing PGTA and not doing a fresh transfer, but doing a frozen transfer with a normal embryo if one is found. Next question. Likelihood of IVF success with low ovarian reserve and tubal factor at age 37. Does previous IVF success factor in? So the and thank you for the nice comments, for everyone who's putting in the nice comments. They're much appreciated. IVF success, the #1 predictor of success is age. If someone is at 37 and has still good ovarian reserve, that would be an overall good prognosis. Low ovarian reserve lowers the prognosis somewhat. So we know that if the ovarian reserve is poor, unfortunately, the response to stimulation may not be as good, and so we're not going to get as many eggs. So there are actually calculators that can be used, they're available on the SART website, for example, SART, Society for Assisted Reproductive Technology. So you can put in your information, your age, your height, your weight, your previous pregnancies, your diagnosis, your AMH level, if it's available. And so with that data, the website calculator will spit out a chance on average in the United States of having a live birth from 1, 2, or 3 IVF cycles. So we can estimate that. But overall, it depends a lot on how low the ovarian reserve is at this age. Previous IVF success does factor in. So someone who recently did IVF and had a good outcome, that's a very positive predictor. So that's something that suggests that there still is good egg quality, hopefully, to give you a good shot at success. In the case of recurrent biochemical pregnancy or miscarriage, so here specifically 2 frozen embryo transfers in a row, leading to low HCG levels, 26 and 8, respectively, is the most likely cause that chromosomal abnormalities, that most likely cause of that also chromosomal abnormalities of the embryos. Yeah, so in general, we blame the large majority of biochemical pregnancies, as these are, on chromosomal abnormalities. Now, it's not 100%. There are other reasons why miscarriages and biochemical pregnancies occur, but statistically, the #1 most likely reason is indeed chromosomal abnormalities. How long does it take normally from the egg retrieval stage to the transfer stage? So that's 5 days, as we were discussing. So once the eggs are retrieved, they're combined with the sperm. The next day, we see how many of them fertilized, and then we follow them for 5 days to do if we're doing a fresh transfer, that would be 5 days after the retrieval. Or, of course, the embryos can be frozen, and then a frozen embryo transfer can happen a month later or 2 years later. It really does not matter very much after that. What types of screening should I do before trying to get pregnant? So there are a number of things that we recommend doing as part of a preconception evaluation. So if you come to see me as a patient, first we would have a conversation in which I would ask a bunch of questions and ascertain, are there any risks of problems during pregnancy? So we're not focusing just on becoming pregnant. We're also looking for giving you the best chance of having a healthy pregnancy and a healthy child. And so the history is the first very important step for ascertaining risk factors. What are things we need to watch out for? What are the things we need to improve or fix prior to pregnancy? And then testing includes, again, not just infertility type tests, but tests that will increase odds of a healthy pregnancy. So we want to make sure that there are nothing wrong in the uterus that could impact the healthy implantation. We were looking at health overall by doing some basic screening for immunities like German measles and chickenpox, and screening for blood counts and infectious diseases. We check thyroid, prolactin, hormones that can impact health of the pregnancy. And then a big category is genetic. In addition to chromosomal testing that we've been talking about so far, we've been focusing on the chromosomes, right? So each one of us should have 23 pairs of chromosomes. These are the big structures. And so when we talk about Down syndrome, that's an extra chromosome 21. When we talk about miscarriages being due to genetic problems, that's having too many or too few chromosomes, the big structures. But then on these big chromosomes, there are over 20,000 genes that are sprinkled throughout, and each one of these genes codes for a specific protein. So the genes are not usually something we worry about for fertility and for miscarriage, but they're rather diseases potentially that can happen in an individual later on in life if there are mutations. We offer screening for what's called carrier testing to see if individuals are carriers, and if they are carriers for mutations, then they may be at risk of having a child with that disease. And so there's carrier testing available to detect if individuals or couples are at risk of having a child with a specific genetic disease. And then if we do discover that someone is at risk, then we can actually test the embryos to see which embryos are impacted and not use one of those embryos. So we can screen the embryos for the mutations and not use embryos that are abnormal. But we need to know in advance in order to be able to use that technology. So that's called pre-implantation genetic testing for monogenic disorders, PGT-M, as opposed to the PGT-A, which is the test for chromosomal abnormalities in the embryos. So that's a summary of all the things that we do prior to beginning the road. That's called a preconception evaluation that we routinely do prior to starting. Next question about freezing. Does freezing hurt the embryo? So it does not. We have found out, again, over the decades about how to freeze embryos safely. The older techniques used what was called slow freeze technology and was not quite as successful, and we did lose embryos in the process. The main problem is why we can't freeze, just go and freeze living tissue and then thaw it and it survives, is ice crystal formation. So we have water in our cells, and as you know, when you freeze water, it becomes ice, and ice expands actually. And so it blows up cells and destroys cellular structures. So cells do not survive freezing. So techniques have been worked out how to prevent ice crystal formation in the cells and in the embryos so that we can freeze them safely. So these days, when we freeze embryos, we have over 98% survival when we go to thaw the embryos. And we think that the few embryos that do not survive are probably not normal in some way to begin with. Next question. So someone who's 40 years old, can I do embryo freezing? Yes. So we can freeze embryos at any age. So at 40, of course, we worry about the ovarian reserve issue, as we've been talking about so far. So someone who's older, if they still have good ovarian reserve and respond to stimulation, can produce lots of eggs and still have embryos that we can freeze. On the other hand, if the ovarian reserve is poor, then there may not be good response, and we may not get good numbers of eggs and then result in few embryos to freeze. But the simple answer to the question is absolutely, we can freeze embryos at the age of 40 or at any age if we have embryos to work with. How can I improve my chance of getting pregnant if I have irregular cycles? The most likely reason for irregular cycles is if someone is not ovulating on a regular basis. And so the first thing to do is always try to figure out why is someone not ovulating on a regular basis and see if we can fix the underlying problem. So is it a thyroid disorder? Is it prolactin excess? Is it polycystic ovarian syndrome, PCOS? Is it ovarian reserve problem? So finding out the underlying etiology, the cause of not ovulating regularly is the first step. And then if that cause is identified and it's not something that's readily fixable, like a thyroid imbalance, for example, then we have medications that we would use to help somebody ovulate regularly. And those medications are called letrozole or clomiphene, Clomid. So we have ways of helping someone to ovulate. If someone is significantly overweight, weight loss is something that can also help ovulation start back up again, if that is the primary cause of the ovulatory dysfunction. Next question. Somebody who is 33 and her partner is 37. So this is a same-sex couple, and the youngest is planning to use her eggs, open to carrying due to being older. Is this decision a wise one based solely on age? Should we test to be sure? Absolutely. So age is the single most important factor, but there are many other factors as well. And so before we start any kind of a treatment process, we first do the basic test to make sure that there's not other issues that would impact the chance of success. And sometimes we find that younger individuals may have more problems or may have health issues that impact the chances of a healthy pregnancy. And it may be better for the older individual to carry the pregnancy. So it could go either way, but in general, younger is better as a rule of thumb. Now, having said that, both 33 and 37 are still good ages for carrying a pregnancy, and overall will have very good chance of success going with either individual carrying the pregnancy. There are a number of options that we can offer couples who are same sex. So indeed, we can do IVF and collect eggs from one female and combine them with sperm, donor sperm, create embryos and transfer the embryos to the other individual's uterus. Or, of course, we can do IVF individually for each partner, or perhaps we don't even need to do IVF, but we can just simply do intrauterine inseminations for each individual, one at a time, or even at the same, roughly the same time period. So there are a number of options that we can go over to discuss and decide what is better for you and what you prefer. Doing testing is always the first step to find out and answer these questions best. Another question about twins. Can multiple embryos be transferred? So in principle, yes, multiple embryos can be transferred, but in practice, it is a very bad idea. Why is that? Well, it's not because I have something against twins. It's simply because I want to give you the best chance of having a healthy pregnancy and a healthy child. And we know that a multiple gestation has a much higher risk of complications. So even twin pregnancies, in the end, most twin pregnancies do okay, but still twin pregnancies are many-fold higher risk of having something go wrong than a singleton pregnancy. And that includes right from the start, the risk of miscarriage to problems during pregnancy, like growth retardation, placental problems, diabetes, preeclampsia. So all kinds of things can happen. And these risks are much higher for twins than for a singleton. So twins are a big problem historically for our specialty. And we have in the past used to transfer multiple embryos. And that is one of the reasons why complication rates in pregnancy went up so much in our country during those years. So in the recent decade, we have greatly reduced the number of embryos we are transferring. And the vast majority now of transfers that we do is simply transferring one embryo at a time. and rarely do we transfer more than one embryo, only in circumstances, rare circumstances, where someone has a very low chance of success, and that makes sense in that individual case. But 99% of the time, we are transferring a single embryo to give the best chances of a healthy pregnancy. In your opinion, what is the minimum thickness recommended for the endometrial lining before triggering for a frozen embryo transfer? So this question talks about when we are preparing to transfer a frozen embryo, there are a number of protocols that we can use to prepare the uterus to create the optimal conditions for the embryo to have a good chance of implantation and success. And there are a number of things that we're looking at to judge whether the environment looks good. And one of them is the thickness of the uterine lining on ultrasound. So when we see the uterus with ultrasound, we can actually measure what's sometimes called the endometrial stripe or the endometrial thickness, the lining of the uterus, which has a characteristic appearance. In general, we have a cutoff roughly of around 6 millimeters, that we want to be above that, and ideally above 7 millimeters, because that seems to correlate with higher chances of success. But it's not as simple as that, because that's just one measure. We're looking at other things as well. So we're looking at the architecture of the lining, its appearance. Does it have a nice 3-white line, multi-layered appearance, or is it or not? Does it look symmetrical? Does it look good or doesn't look good? We're looking at hormone levels. We're looking at history. So some women may not be able to get a thicker lining despite whatever attempts, manipulations that are undertaken. And in those individuals, we've seen still very good pregnancy rates, implantation rates, and success overall. So simply a thin lining by itself may not be prohibitive for a successful transfer and successful outcome. But yes, we overall try to make everything as optimal as possible, and that includes trying to push a cycle a little longer to see if we can get the lining a little bit thicker. Does placental injection to ovary help with fertility outcomes? So I'm not sure what that's referring to. There are a number of techniques that have been attempted to try to improve egg quality and quantity, to improve ovarian reserve, to improve response to stimulation. And unfortunately, none of these have been shown to be beneficial in any rigorous study. So there are a number of techniques that are still under investigation right now that we continue to examine and see if they hold promise. But right now, there's nothing available that I can say with any degree of certainty that makes any difference or helps at all. So none of these injections into the ovary is considered standard treatment, and if performed, is usually performed only under a research protocol. Do you recommend laparoscopy or hysteroscopy for testing? So laparoscopy is a surgery where we take a camera and put it in through the belly button and look and inspect the pelvis. Hysteroscopy is a surgery where we take also a camera and now slide it in through the vagina, through the cervix, into the uterus, and inspect the inside of the uterus. The hysteroscopy is something that's really minimally invasive because we don't have to cut any holes. We're just using a natural opening to go inside. It's usually, if you're using a very small camera, it's usually very well tolerated, minimally uncomfortable, and extremely safe, minimal risk of anything, infection being the only thing that's any kind of risk at all. Even that is very, very, very low, well below 1% risk. So we often utilize hysteroscopy in the office to check the uterine cavity to make sure everything's okay. So yeah, hysteroscopy is a great diagnostic tool. And then we can also use hysteroscopy as a treatment. So if we do find problems, then we can do operative hysteroscopy, where we can put other instruments next to the camera to remove polyps, fibroids, scar tissue, whatever's wrong inside the uterus. Laparoscopy now is a different story because now it's something that's more invasive. We have to make openings in the abdominal wall, and so it's a bigger surgery. as a bigger surgery, it means there's a little bit more risk. It's still minimally invasive and very safe overall, but certainly does have a greater level of invasiveness. And then afterwards, there's more discomfort and recovery time. So laparoscopy is something that we do not do often anymore because it does not often improve our success rates for the goals that we're trying to accomplish, which is usually fertility. Now, if somebody has a reason to do laparoscopy, if they're in a lot of pelvic pain, if they have cysts on the ovaries that need removal or investigation, there are clear reasons why we still do laparoscopy. If there's an ectopic pregnancy that needs to be removed surgically. So there are many reasons why laparoscopy is extremely useful, but it is not part of our standard infertility evaluation. How many rounds of IVF do you have a person do before telling them it's time to move on? There is not one such number. It varies dramatically. So if someone is responding to stimulation, if we're getting embryos but just haven't had success with transfers, if something goes wrong in the cycle, but overall we still think there's a good chance of success, then repeating IVF multiple times is not unreasonable. And in fact, there have been studies that show that even individuals who failed 2 cycles still have a very good chance of success on the 3rd try, if it's appropriate. Now, there are other circumstances where doing more cycles just does not make sense. So someone who is much older, say someone who is 44 years old with diminished ovarian reserve, maybe if we attempt IVF at all, we'll do 1 cycle. If there is no response to stimulation or very little response, it simply does not make sense to keep putting someone through these treatments that take a lot of effort, time, cost, money, and do have risks. So those are the cases where it does not make sense to keep trying. And I always urge a discussion in every individual case so that we can make a decision together whether it makes sense to try another cycle of IVF or not. Again, thank you for the nice comments. It is my pleasure to be spending some time with you folks today and trying to answer any questions and raise awareness of infertility and health. I'm 38 and have no partner. Any chance I can freeze my eggs, or should I freeze embryos? So absolutely, 38 is still not too late to freeze eggs for the future. Hopefully there's still good ovarian reserve so that we can get a decent number of eggs that we can freeze. The chance of success in the future, if we freeze eggs, largely is predicted by the age at which the process is done and the number of eggs that we're able to freeze. The younger someone is, the better the chance of success. The more eggs we freeze, the better the chance of success. Sometimes at 38, we can do more than 1 cycle to freeze more eggs. Again, the more eggs, the better the odds in the future. Freezing eggs versus embryos. What's the difference? Well, if we freeze eggs, you have all the control and flexibility in the future so that if 4 years down the road, you meet someone that you want to have children with, then we can use his sperm to inseminate the eggs and create embryos and give you the chance of success that you're looking for. Or if you do not find someone that you want to have children with and you want to have children on your own, or either way, if you want to use donor sperm, that is very much an option at any point. On the other hand, if you freeze embryos, that means that you are locked in to having children with the individual whose sperm was used. So if you use donor sperm, then you will have to have, if you transfer those embryos in the future, you will be having a child that was created by the donor sperm and your egg. Is there an advantage to freezing embryos? Yes. So egg freezing is not quite as successful, we can say, as embryo freezing. So earlier I said that when we go to thaw the embryos, we have over 98% chance survival of those embryos. we do not get the same percentage of success when we go to thaw eggs. So it's lower, and it can vary from person to person, and it's very difficult to predict who's going to have a better survival rate and who's going to have a worse survival rate. So we have more certainty, more ability to predict success from frozen embryos than from frozen eggs. But to freeze embryos, that means, again, you are committed to having children with the partner or the donor sperm that was used. And so most of the time, for single women who want to freeze eggs, single women who want to preserve fertility, we are freezing eggs as the #1 choice because it gives that flexibility that most would desire. So yes, if you are interested in fertility preservation, I strongly recommend going in for a consult and an evaluation as soon as possible, because the sooner you do it, the better the odds of a better response and better odds of success in the long run. Next question. So my husband and I have been trying to conceive for 8 months with no pregnancy. 37 years old and 39 years old. My family has history of miscarriage. Should we be aggressive with treatment from the start? I don't want to go through many rounds of lower chance IUI considering the history. How do we come to that decision? So yes, overall, for women who are over 35, we recommend that you initiate an evaluation after 6 months of unprotected intercourse without successful pregnancy. So it's been more than 6 months in this case, and therefore I would not wait any longer and come in as soon as you can for an evaluation. Being more aggressive is up to you in general. It depends on what the situation is. So when you come in for an evaluation, we are going to do a history and we're going to do a bunch of tests and see if we can identify what are the issues that we're dealing with, what are the problems, what do we need to overcome. And so if we find specific problems, we'll talk about how those can be overcome. If you find no specific problem, and so then we make the diagnosis of unexplained infertility, in those cases, you have to decide how aggressive you want to be. And so that is, again, part of our discussion. So we take time and I explain the options to you, explain that what are the pros, what are the cons, and then decide on what treatment course is best for you. In general, the more aggressive you are, the higher the chance of success, but the more work, time, cost, effort involved overall. And that's a very individual decision that I would help you make at that time. But the first step is always doing a thorough evaluation, and then having that data, then we can give you better advice and we can make a decision together about what is best in each case. And since, again, the theme tonight is infertility awareness, the important point here is not to delay. So over the age of 35, that's 6 months of unprotected intercourse without successful pregnancy. That's the time to start doing testing to see what's going on. All right, so next question. 3 rounds of frozen embryo transfers, 4 PGT tested embryos, all day 6 or 7, 1 successful but miscarriage, 1 unsuccessful transfer, 2 to remain frozen. How many rounds should you do? And what are odds of future embryo success with another round, age 39 and 40? So these situations are always challenging, and I definitely would want to have more information about what else is going on. What are the other issues involved? In general, if we do IVF and create an embryo, then test with PGTA, when we go to transfer that embryo, we expect a high success rate. It's not 100%, but in our office, it's over 60%. So definitely any embryo that's PGTA normal should have a very good chance of success. So if there are still frozen chromosomally normal embryos left, those should have good chance of success. So they should very much something that we expect. So you've had 2 embryos that were transferred that were normal, but one was a pregnancy loss and one did not implant. We would want to make sure that there's nothing else that's interfering with your chance of success. So this is when we're going to be looking at the uterus very carefully to make sure nothing is wrong inside the uterus. Sometimes we consider tests that are outside the basic tests that we do as part of the infertility testing. There are tests that we look for infection inside the uterus, something called chronic endometritis. There are tests that we look to see sometimes if the timing window for when we're doing the transfer is appropriate. Sometimes we're looking for other organisms that are inside the uterus. So the thing that we most are concerned with this type of situation is making sure that the uterus is fine and there's nothing else that's wrong inside the uterus that could impact implantation. So those are the tests that we would be considering after two failed euploid embryo transfers. The individual's age no longer matters once we've created those embryos and those embryos have been found to be normal. Not entirely, I shouldn't say it doesn't matter at all. The risk of complications in pregnancy rises as someone gets older. So waiting much longer number of years would increase the risk of complications in pregnancy later on. But for the immediate time period, the age becomes much less relevant. How long would you recommend someone wait for an egg retrieval cycle following an uncomplicated ovarian cystectomy? Great question, and we don't have great data to make that recommendation. So it's mostly a individual subjective decision. In general, ovaries seem to heal very quickly. And so in practice, we usually wait a month. Doesn't probably need to be any longer than that before proceeding with ovarian stimulation. Are lower grade embryos correlated with having more chromosomal abnormalities within those embryos? So there have been a number of studies that have been done to look at what's called morphology, the appearance of the embryos and how they correlate with chromosomal abnormalities. And many of these studies, when done properly, have indeed shown a correlation. So the better looking embryos, the embryos that have the higher grading, seem to have lower chromosomal abnormality rates. And conversely, the embryos that have lower grades will have a higher rate of chromosomal abnormality. So there is a correlation, but it is not a perfect one at all. It's a rough correlation. So doing morphology, the grading of the embryos, is a rough guide to success when we go to transfer those embryos. And that's, if we're not doing PGTA, we use the grade to guide the order in which we will select the embryos for transfer. So I think we are reaching the end of our 1 hour. Again, appreciate the very nice comments in the chat, and it's my pleasure to be doing this hour discussion with you all today. I will end simply again by emphasizing that infertility is a huge problem around the world and in the United States, and affects all levels of socioeconomic class, race, geographic. It has no distinctions. So infertility affects all elements and aspects of society. And the only thing that we can say is that trying to have children earlier in life, completing childbearing earlier in life, translates into better chance of success. And if we are working later in life, the odds of success are lower. Now, it doesn't mean that if you find yourself later in life in a situation where you have infertility, that it's too late. It's always worth it to come in to have an evaluation, a discussion, and to find out what the options really are. But the number one recommendation today is to be aware of age and how it impacts fertility, and not delay childbearing if possible. I thank you very much for joining me tonight, and I wish you all success in your fertility journeys wherever they take you. Have a good night.